A 25-year-old woman comes to you complaining of a vaginal discharge. She tells you that she has often had yeast infections, but that she has treated this one with an over-the-counter medication for yeast infections. And this time, the infection has not gone away. She has also experienced a burning sensation during urination and had some spotting between her last two periods. What disease would you suspect, and how would you test to confirm your suspicions? So, what could it be? First, I looked at chlamydia and gonorrhea. Both, as you can see on the slide, have the following symptoms: abnormal foul smelling discharge, burning sensation upon urination. There may be swollen testicles, scrotum, or pain upon ejaculation. And oral sex with an infected person can cause a sore throat and a cough. So in both cases. In our case, the causative organism was the bacteria Neisseria gonorrhea. This bacteria causes sexually transmitted infection, which can infect the urogenital, rectal, pharyngeal, and conjunctiva mucosa of exposed persons. The World Health Organization reported 30.6 million cases in 2016, and it's easily transmittable during sexual activities. Patients can be asymptomatic, or there may be symptoms which appear within a week. The characteristics, these are some photos of the morphology of the colonies. And you can't see in the photograph here, but the color is pinkish brown, diplococci. This photo shows a pigmentation of clear gold brown coloring after autolysis of the cells. And here's a photo of an oxidase test. And a rapid acid detection test. This test here is looking at the metabolism or fermentation, although they're not called, this test is particularly not called that. It's precisely called a rapid acid detection test. Organisms which produce acid will have a color change on this test from red to yellow. Polysaccharide is not produced. And these are some additional lab tests: the superoxyl, the catalase test, and the colistin resistant. There are many antibiotics which are resistant to treating this bacteria. So there are 3 levels of diagnosis, because we really need to be sure. There's the suggestive, presumptive, and the definitive diagnosis. You can see here that the suggestive diagnosis could be a affirmation of sexual exposure, or with a infected person, a known infected person. And you may also have mucopurulent discharge, or urethral exudate. The presumptive diagnosis would mean that you had one of 3 criteria have been met. So gram-negative, diplococci, oxidase positive, no culture, but you have antigen testing, and then we have our definitive diagnosis, and we have to be really careful to avoid misidentification and misdiagnosis. So definitive diagnosis happens when we have isolation of this urethral, endocervical, rectal, or pharyngeal secretions, and we've isolated and cultured them on a medium. Then we have confirmation testing. It could be biochemical, enzymatic, serological, the nucleic acid amplification testing, rapid enzymatic assays, direct specimen tests like the GEN probe, or the fluorescent antibody testing. So, what causes this organism? Hello, unprotected sex, improper condom use, and also an infected mother can pass it to her child during childbirth. Who is at highest risk? Obviously, people with multiple sex partners, douching, people. So it's best to avoid any unnatural products. Prior STDs, STIs, sexually transmitted infections in the past make you at higher risk. International travelers and sex workers. The World Health Organization reported a growing population of sex workers. Also, same-sex networks, circuit parties, group sex, chemsex, I had never heard of, and HIV PrEP, also had not heard of. So, treatment, how do we treat this? That's an issue. Currently, treatment consists of the antibiotic Rocephin or ceftriaxone. It's an injection given intramuscularly, along with a dual treatment of oral azithromycin. If left untreated, you can have a number of problems, including pelvic inflammatory disease, ectopic pregnancies, spontaneous abortions, tubal factor infertility, chronic pelvic pain, and it could lead to bacteremia, disseminated gonococcal infections, septic arthritis, endocarditis, and even meningitis. Retesting after 3 months of treatment is recommended by the CDC. And also just a note that infections may be antibiotic resistant. We've already had cases of antibiotic resistance with some strains of gonorrhea. Okay. All right. Matter of fact, in the past, let me just go back. Well, actually, how to avoid getting it. We'll just move on. Use protection, proper use of condoms, any sex, limit sex partners, monogamy is best, test yourself, CDC recommends testing annually. So just ask your doctor to give you a test, and avoid douching and use of irritating products. And finally, this is just a photo collage that I put together representing back throughout history, many people have succumbed to illnesses from gonorrhea and other STIs, including famous artists. So this was my hello to all of them. So anyway, we've learned a lot since then, and we have a lot further to go. So hopefully we'll find a cure and reduce the incidence of gonorrhea. And here's my references. Thank you.